Thank you, Dr. Rashad. You've basically covered, given a very good preamble for what we are discussing next. And I'll be speaking on behalf of Dr. Rohit Shetty because of some air shows, some flights have been preponed and postponed, which is why he had to leave a little earlier. So what are the newer paradigms that we are looking at in dry eye disease? Most importantly, let's just approach these dry eye disease by just one case example which has intrigued most of us in our clinic. So this is a 55-year-old ophthalmologist. She's quite symptomatic. She was diagnosed as moderate MGD, has evaporative dry eye disease, and she's very unhappy with all the treatments. And imagine she's been diagnosed for dry eye disease and on treatment for 18 years now. So if you actually speak to her in detail, she gives you this chart, and she has tried out every medicine on earth, and then she'll tell you, with this combination, the pain relief that I get or the score that I would like to give out of 10 is this much. So she's basically tried every single drug therapy individually and in combinations, and she tells you that this works best for me. So if somebody is so receptive and she's still not able to find the right answer and we're not able to give her the right treatment, what is it that we need to look at? So this is when we started looking at in a slightly deeper, to understand dry eye disease slightly deeper. So there are tear phantoms, as we call them, and most importantly, this was one of them that we started exploring. If you look at it, it says that dry eye disease also has got some role with the emotional state, as in people who have got PTSD or have stress disorders, or there is some weak correlation that still exists. What we did was we wanted to probe further and see. So there is definitely an inflammation depression axis. So if there is inflammation either generalized in your body or localized to a particular organ, it certainly causes some amount of depression. And this depression is what sort of sets it into a vicious cycle which causes more inflammation, and we need to break this cycle. So essentially what we looked at in this case, after doing a thorough literature review, we found that nutritional status of an individual, also the gut microbiome. Now this is something which comes as a surprise to us also. The gut microbiome, or the commensals in the gut, are something that determine the health status, the mental health status also of your body. Now there's a lot of research going on this as well. We still to understand this in a little more detail, but vitamin D, earlier when we were treating dry eye disease with vitamin D, people were like, what is the role of vitamin D? But there's enough and more evidence now that vitamin D does have a role, well, not only in inflammation but also on the depression. Why are we discussing all this? Is because the behavior of eye, the behavior of a response to the body is changing with time, it's changing because of the inflammation. And essentially, what are we looking at today? We are looking at specific drug targets, very, very customized treatment for each individual patient that comes to us. Why is this? Let me explain you with, let me just detail it with this example. Now in 1970s, whatever was the population, if there is any dysregulation, it had a lot to do with the local microbiome as well as the gut microbiome. Most importantly, it is dependent on our lifestyle and the kind of food that we eat. Now, this is what determines the outcome of the treatment also, which is why I'm sure the old age thinking that you have to eat well before you go for surgery, you have to develop your immunity, that still holds true. Over a period of time, we have seen that our microbiome has changed. Why? Because our lifestyle has changed, our diet has changed, and this again determines how our eye responds or how our body responds to any sort of treatment. So which is why it is important that we want to, understand all this, incorporate into our clinics. But let's go back to our 55-year-old ophthalmologist. We wanted to understand now if she's complaining of pain constantly, she's not happy. So we wanted to see how is the paradigm of dry eye expanding so much. Now this brings us to the DUCE-2 classification, which was recently worked on. What's new? Dry eye disease now takes 43 words to define dry eye disease. So you can imagine the multifactorial component that the dry eye has now. Most importantly, the new addition was the neuropathic component in dry eye disease definition by Deuce 2, which explains the so-called pain or the sign not proportionate to symptom part of dry eye disease. So what we did was we wanted to see, whenever there is pain, we think of nerves. We wanted to see what is driving pain in dry eye disease. This will be, of course, covered more in detail by Dr. Rashmi. But just a small preamble to that, what we did was, in a dry eye disease cohort, we looked at the nerves and we saw that there were increased dendritic cells. Now this has been published. There is increased dendritic cells, be it mature or immature. But what are we looking at is the nerve patterns. Now if you look at, these are the normal nerves, the images on the top, the A and B. The image on the C, it basically is what we look at a confocal image where there is nerve tortuosity, if there is a neuroma or if there are bleeding. Essentially in this case what we found was that the nerves were fairly okay. There was in some cases decreased nerves, but in some areas there was increased dendritic cells. Most importantly, what we found, this is another case, what we found was there were microneuromas. Now these neuromas are, it's been published that these neuromas are responsible for the pain component of dry eye disease. Now we have published, our group has published this, where we have basically looked at, if we, the Bowman's imaging, which is a high resolution imaging, we have noticed a break in the Bowman's layer. Now this break, our hypothesis was, when we correlated this on the confocal imaging, our hypothesis was that there was a neuroma approximately in the same region. Unfortunately, there's no way to mark it because there are no surrogate markers when we do confocal or when we are doing the OCT. So essentially, it's just a visual axis that works as our marker. So essentially what we found in this case was that this patient had breaks as well as had microneuromas, which was explaining the pain component or the neuropathic component of dry eye disease that we experience. So in our case, in this lady who's an ophthalmologist, her confocal nerve analysis did show some amount of dendritic cells. Over a period of time, we wanted to see if this corresponds to the molecular component. So what we did was we looked at the molecular signature. We collected the tears. Essentially how we do is we collect these tears, put them in microphage tubes, sterile tubes. These tears are stored at -80 degrees. Of course, they undergo tear extraction, and depending on what are we looking at the end of the day, either they undergo flow cytometry or tear proteomics. So this tear cytokine analysis, which happened on the flow cytometry, in this case explains that there is increased amount of inflammation and increased factors which cause nociception. So the anti-nociceptive factors go down and the pro-nociceptive factors go up, which explains why the patients experience pain. What we have also started doing is that this is what we call as the ocular wash for the immune or the immune wash. Essentially, the ocular surface is washed and the entire wash is collected in a tube. Now this tube is sent for analysis, which has got the cells. Now interestingly, what we found was that most ocular surface inflammation have got similar kind of inflammatory cells that are significantly elevated. Now dry eye disease as well as keratoconus, these days we are also calling keratoconus as an inflammatory disease. So while they have inflammation, similar markers, but the signature is significantly different for keratoconus and dry eye disease. So what we see here is that there are natural killer cells increase significantly in keratoconus, but not so, it doesn't happen so in dry eye disease. So what do we translate by this is that we have the ocular surface inflammation, no matter what kind of inflammation, differing from dry eye disease to a different spectrum of dry eye disease, has different signature, and this helps us understand dry eye disease slightly better. What essentially are we looking at here is if there are specific drug targets. Now the dry eye disease, NEJM, paper published in 2018 says that cyclosporin acts as a mainstay treatment for dry eye disease, and it has been FDA approved as well. Why does this happen is when we looked at this signature, restasis and cyclosporin tend to block the pathway, the intersignaling pathway, which essentially start the inflammatory milieu that gets collected. So the chemokines are blocked, which essentially stops the stromal changes that happen, the epitheliopathy that happen, also the inflammation and the nociceptive factors. So restasis is justified, or cyclosporin, this specific experiment was done with restasis. So this is justified when we are using these anti-inflammatory mediators. So going back to our case, now we know that the patient who has our ophthalmologist, she has pain without stain. She has been on treatment. She's a non-responder to the treatment. So what are we looking at? What is the missing link? When we looked at the tear cytokine profile, of course, this tear inflammatory signaling was different in this patient. There was definitely an increased tear inflammatory profile, but none of these factors respond to our conventional treatment. They don't respond to restasis. They don't respond to the conventional treatment of Trehalose, which is being used now, or tacrolimus. So what we essentially did was we probed a little further, and we found that autologous serum also has got anti-inflammatory and increased anti-nociceptive factors. Also, it is very, very effective for the corneal neuropathic component. So essentially what we did in this case was we just deducted all her medications that she was on and put her on autologous serum. Surprisingly, this case has helped us understand dry eye disease a lot, because she got better only and only with autologous serum, and none of the other factors were helping improve her symptomatology. Just a word on what are the newer treatments that we are seeing. We are seeing the light modulation treatment, which again theoretically is known to decrease the inflammation and decrease the nociceptive component. Vitamin D will be spoken in detail by Dr. Rashmi. So what are we essentially looking at? Just to combine the whole talk, we are trying to put all of this knowledge from the molecular aspect of it. We're trying to clinically translate it essentially by putting a point of care diagnostic kit. So some of us who have been attending a few of the dry eye meets or the keratoconus talks by Nara Netralaya group, there is a small kit that everybody must be showing. It's a very small handy kit. Essentially this is based on sandwich ELISA method. You can collect the tears, just put on this. It's a very small, like a glucometer sized diagnostic tool. We just need to put that kit inside it, and we get readouts depending on what antigens we are specifically, antibodies that we have incorporated on the kit. Our approach to this is that we need to integrate all this knowledge, and we have to look, as Dr. Rushad rightly covered, from the tear film, the composition of the tear film, look at the ocular surface and in entirety, how is the ocular surface, what is it composed of, and specific drug treatments need to be discovered a little more in detail, because we still are at a horizon where we are not able to find the perfect treatment for dry eye disease. Thank you very much.